Good morning, everyone. I gave this lecture probably either last year or a couple years ago. I can't remember offhand. There's been slight changes and modifications made to it. We're going to talk about a few things. Oops, that's not there yet. But basically, we're going to talk about elder abuse, elder neglect, DNR orders, advanced directives, informed consent, the origin of informed consent, a little bit of tort law. Really quick overview. We're not meant to go in depth, but hopefully it'll apply clinically for everything that you're doing. Okay, now this is the fun part, right? With the clickers. An 85-year-old female with mild dementia presents in acute on chronic renal failure by EMS without a family member present. The patient is told that she needs emergency hemodialysis or she will die. You ask her for permission to place a perm catheter to proceed with the treatment. In terms of medical decision-making for the elderly, which of the following should be done first? So is it A, capacity determination, B, competency hearing, C, contact family appointed designate of surviving children, D, discuss with executor of the patient's will, or E, contact durable power of attorney for health care? So I'm going to start this up, I believe, and you guys click away on what you think is the right answer. Everybody answered? We're good? Okay, so everyone, 55% of you versus 40% of you picked A. So A and E were probably the two most, right? That one lonely person, we won't call you out, picked competency hearing. Okay, so the correct answer is indeed A, right? Capacity determination, and we're going to talk about why. Here's another one. We have like 3 pre-test questions, so we're going to have this little clicker function. An emergency medicine attending and his subordinate emergency medicine resident were on a flight to Las Vegas for an annual medical conference, because I think the ACOEP is always in Vegas, right? I believe. During the flight, just like emergency medicine physicians, during the flight, an elderly male began choking on his in-flight meal. After multiple attempts of the Heimlich maneuver, the resident used a small pocket knife to secure a patent surgical airway. I don't know how he got on the plane. Ultimately, the elderly gentleman recovered, but developed an infection at the surgical site. As a result of these actions, which of the following is most likely? A, the attending physician will assume liability. B, the resident will be charged with assault. C, the resident will be charged with battery. D, the resident's actions are protected through an emergency exception. Or E, the resident would be liable under the doctrine of strict liability. So we're going to, start. Sorry. So let's see what everybody thought. Overwhelmingly, right? 80% of you picked D. All right? And then the 10%, I guess a 10% even distribution, picked C or E. The resident will be charged with battery, or E, the resident will be liable under the doctrine of strict liability. The answer is indeed C. It's an emergency exception, right? I'm sorry, D. I can't even read today. Okay, and we'll talk about that topic later, right? Last one. An 80-year-old male presents to the ED with paramedics for respiratory distress. He makes it clear that he wants to return home after treatment for his shortness of breath. You assess that he has capacity to make that decision. On exam, he appears quite disheveled. He is unshaven, malodorous, and is covered in feces. Come on, you see this. Despite this, there's no bodily injury that is apparent. Paramedics noted the home is dirty with multiple pets urinating, defecating in the house. The patient apparently lives with 2 of his children. What is the appropriate next step? Is it A, send the patient home with a visiting nurse? B, contact adult children? C, contact adult protective services? D, call the local police? Or E, notify the judge on call to appoint emergency guardianship? And we're going to start it up. Let's see what everybody picked. All right, overwhelmingly, C, contact Protective Services. And I guess you guys did your homework. Yes, that is correct. Okay? All right, so like I said before, we're going to talk a little bit about medical ethics, informed consent, DNR orders, your do not resuscitate orders, Wells Advanced Directives, living wills, durable power of attorney, guardianship, elder abuse and neglect, and we're not really going to cover physician-assisted death. That's kind of like that's a bigger topic, obviously, with euthanasia and what have you. And there are different statutes that have been popping up over the last few years addressing that. And I don't think it's anything that you necessarily want to do in the emergency room. Okay. All right. With our medical ethics, there's a few principles here. You may have heard this in medical school or other types of lectures where you have like a professionalism class or an ethics class. But basically, we hold these tenets to give the patient autonomy, right? Make their own medical decisions. Beneficence, which is to treatment in the best interest of the patient, and non-maleficence, the so-called first do no harm. The last one that sometimes people incorporate in here is justice, but we won't be talking about that in this lecture. The law tries to capture the spirit of these principles. So whenever we try our best to see what our ethics are as a society, and then devise rules to actually guide us in actually performing these ethical principles that we sort of agree upon, right, as a society. Now, I'll tell you that there are times when legal and ethical principles do not necessarily coincide, right? What's legal is not necessarily ethical. What's ethical is not necessarily legal, right? So I like dealing with hypotheticals, so we'll go through a couple of them. A 65-year-old female is taken to the ED after a head-on motor vehicle collision. She is unconscious and has several fractures. She becomes hypotensive and appears to be in shock. The physician wants to administer a blood transfusion. At the same time, a nurse discovers a card that states the patient is a Jehovah's Witness. What do you do? In general, what would you transfuse this lady? More or less? So the vast majority of people would probably transfuse this lady in this situation, right? Because just given a actually, would you transfuse or not transfuse? This is the classic example that they give you in medical school, and also you might have seen a couple of times in the ER where someone is Jehovah's Witness. Now, you guys probably wouldn't transfuse, or you would in this situation? You would. Okay. I'll tell you that vast majority of the time, if you can prove that they're Jehovah's Witness, you probably would not, right? Because there's a lot of legal precedent behind that. Correct. Now, see, I was banking on you guys would not transfuse because you saw a Jehovah's Witness card, right? But same patient as previous, let's tweak it a little bit. She's unconscious, no family's present. She continues to become profoundly hypotensive. You notice that the aforementioned card has no date on it. You also notice that it is not witnessed and it is written in French. Would you change your mind on treatment? So would you not transfuse, or you still would continue to transfuse? Okay, still continue to transfuse. Now, I'm not necessarily making this up. This is actually a court case that happened in Canada, where they actually saved the patient's life because they did transfuse this patient, and the patient sued, and it was considered a battery. Okay, that from the evidence gathered that the Jehovah's Witness card, regardless of whether or not it had a date on it, or maybe sometimes people change their minds, they switch religions, they're not sure about certain things, but nevertheless the court held in favor of this patient. So informed consent was not obtained, at least in this case per se. Patient autonomy, and this just teaches us, patient autonomy is paramount. So we have these other principles, right? Beneficence and non-maleficence, but from what we gather, it's not as important as a patient's self-determination, right? There used to be, I guess, about 30, 40 years ago, where physicians took on more of a parental role, right? I'm the doctor, you do what I say, that's it. That's no longer, tolerated, at least in our legal system and in our society. So informed consent is a big portion of that. Okay, so the origin of informed consent, this is just a little bit of a minor history lesson. So the doctrine was actually conceived from the intentional tort of battery, okay? There's an old case that we went over in law school. It must have been like from 400 AD or what have you, 500, something old English or what have you. It was literally one paragraph. That's the shortest case I ever read in my entire life in law school. So it was one paragraph, and basically we had there's a physician that came to a person's house. They delivered the baby, and the baby was fine, mother was fine. This person got the intentional tort of battery because they laid their hands on this patient without permission. Okay, so it goes back to those times. Now, later Justice Cardozo, he sat on the New York Supreme Court. If you look at early tort law, he's like famous, and they have the Cardozo Law School, I believe, in New York, named after him. So in one of his famous cases, the Palsgraf case, every human being of adult years and sound mind has a right to determine what shall be done with his own body. So that kind of set the tone for these later court cases coming down the line. Now, I'll tell you the part of standard of care. We always talk about a standard of care, right? Whether it be a national standard of care, a regional standard of care, a local standard of care. And this standard of care is determined by who? Who do you think? The experts, right? Whenever you come into a court of law, you have the battle of the experts. And they're going to decide what actually is the standard of care, and they're going to try to use as their armamentarium or evidence, journal articles, guidelines, what your college, suggests is the best standard of care. So this is very, very flexible, right? The standard of care. Now, informed consent, the standard of care may apply. In intentional tort, there is no standard of care. You laid your hands on somebody without permission, boom, battery, done. Right? You don't need an expert to tell you that that's what it is, right? And when there is a standard of care does apply, it's treated as a negligent tort, right? Negligence, as you may or may not know, is duty, breach, causation, damages, and that's when you have, your judge is the finder of law, your jury is the finder of fact, right? So basically, these two experts are going to battle out in the courtroom, and the jury is going to decide who's telling the truth out of both of them. Quick schematic. Out of tort law, it's usually divided into these four sets, and this encompasses a whole entire semester in law school. Negligence, which I told you about, duty, breach, causation, damages. Vicarious liability, right, where liability is carried forth to another person for what the said person did. Intentional torts, like I said, the tort of battery, assault and battery, is probably the most common. And then strict liability, which usually has to do with medical devices, food, like tainted food. Those things are like what we call a slam dunk, where you're liable no matter what. There's no way you could defend yourself. If you find a foreign object in a can of food, you shouldn't be finding it there, right? That's like an example of strict liability. Now, the standard of care, like I told you before, in tort law, you either have those that require standard care, those actions that require standard care, or don't. So those that don't, an intentional tort like battery, like we talked about, and then do you guys remember this term? Res ipsa loquitur. You may have seen it on Complex 2. I probably wrote a question about it. In Latin, it means the thing speaks for itself. The common example, you do surgery on a patient, you leave a sponge behind. You don't need an expert to tell you that that's wrong, right? Res ipsa loquitur. For standard care is your classic negligence suit. That comprises about 95% of medical malpractices, maybe even more. No standard care, this is just another representation. Strict liability, like I said before, I gave you the canned food example. Fraud and misrepresentation usually don't have standard of care. They deal with elements such as deceit, and financial gain on one party's behalf. There's like about 6 or 7 elements that comprise fraud and misrepresentation, but no standard of care is really needed for that. Assault and battery, like I told you before, is an intentional tort, so you don't need an expert to tell you if it's right or wrong. It just is, right? And like I said before, it started with intentional torts, assault and battery, and actually from that intentional tort, the assault and battery tort, is where informed consent was derived, and we're going to talk about it a little bit. Am I going too fast for you guys, or you guys know everything? You know everything, of course. Okay, so the origin here. Let's, patient consents to an aortogram. Patient never advised of risks associated with contrast medium. Should he or she have been? Yes or no? Yes, right? Now this is incredibly obvious to us now, right? You know you're going to get IV contrast dye. If you have some renal compromise, maybe you'll worsen, right? Obvious to us. In the 1950s, not so obvious. So in this case, Salgo v. Leland, Stanford, versus the University Board of Trustees, this is where the term informed consent came about, back in 1957. And they derived it from that intentional tortive battery. So but it never really described what it was. It just said that it should have been obtained. There we go. Elements of informed consent. Now, this is derived actually from a body of case law where we have certain elements that you need to cover, right? And this is in your basic probably document that you see for all your procedures, central lines, surgeries, blood consents, what have you. You have to describe the procedure or treatment, you have to explain the risks and benefits, and you got to discuss alternative treatments. That is kind of like that's what's mandated to really adequately obtain informed consent. On top of that, you have to require what's called capacity. So capacity versus competency, right? We always talk about capacity is determined by a physician, competency determined by the court system. When someone's declared incompetent, they completely strip you of your rights as a human being. Completely strip you. You are now under guardianship of someone else. A physician does not decide that, right? A physician decides, do you have capacity? And this capacity, at the same time, you have to decide, do they have capacity to make this particular decision? I don't care if they can balance a checkbook or not, right? You worry about, can they consent for whatever treatment I am giving them? Do they understand the ramifications and the risks of that treatment? And you can decide that. You have the legal right because you have an unrestricted medical license that allows you to determine this, okay? Everyone thinks you need psychiatry to give you, to see if someone has capacity. Not necessarily true, okay? I think a lot of us do it just to cover yourselves, right? More or less. Now, like I said before, standard of care can apply to informed consent at times, right? This is derived from assault and battery. There's no standard of care in assault and battery. But depending on what state you live in, you could have a standard of care that applies to informed consent. So you have and then the standards of care the standard of care is mostly for disclosure. How much information should you be giving this patient so they can make that decision, right? So there's a physician-based one and a patient-based one. And we'll go over the cases real quick. Physician-based, the Nathanson case, the amount of disclosure based on what physicians would disclose given the same circumstances. So you're taking it from a doctor's point of view. If you're a physician, what do you feel is necessary to tell the patient for them to consent? So this is a little bit one-sided, right? Because you're the physician. You have almost like a bias, right? Where how do you know exactly what this patient will need, what information this patient will need in order for them to gain adequate informed consent? And that's one of the problems with it, right? And it's based solely on physician discretion, and the plaintiff has to produce expert testimony. Whenever, they always say the plaintiff has the burden of proof. The plaintiff is the person that actually files the complaint, right? So as a matter of law, they have to produce expert testimony, right, based on this standard, to say, hey, I did not have the proper amount of disclosure to make this decision. The patient-based one, standard of care, was actually introduced by Canterbury v. Spence, very famous case. The amount of disclosure determined by what the reasonable patient would want to know about the treatment. In your first year of law, my first year of law school anyways, we had something called ORP, O-R-P-P, the ordinary, reasonable, practical, and prudent person. It's a make-believe person, right? But basically, whenever you set up a standard, a reasonable standard, right, you have to decide, if it's physician-based, what would the ordinary, reasonable, practical, and prudent physician do under these circumstances? So at the same time, on the patient side, what would the ordinary, reasonable, practical, and prudent patient expect, as far as amount of information in order to make a very good decision on whether or not this treatment is valid, right? Or whether or not this treatment is for them. So when you have the patient-based one, expert testimony is no longer necessary, right? Because it's from the patient side, not the physician side. So they thought by focusing on the patient, they thought that autonomy and self-determination was preserved in this case. All right, but beware, there's some states that use a subjective standard to this, right? Subjective meaning that instead of the ordinary, reasonable, practical, and prudent person, it's that individual patient. So there's a very big bias on that. Now, a lot of states have used case law statutes to pick one of the standards, or there's actually some states that have a hybrid of them. Some states with the physician-based standard, Delaware, Florida, New York, Nevada. Patient-based standard, New Jersey, California, Pennsylvania, and Texas. So we're going to deal mostly with the patient-based standard, at least in this area, right, in this region of the country. And I can tell you right now that California and New Jersey are always on the cutting edge as far as the law is concerned. They are known to be incredibly progressive. And your hybrid states that kind of have a mix of both of these are Kentucky and North Carolina. Presentation of information. There's different modalities, different ways to actually express, discuss the procedure and the treatment, right? Number two, you want to describe the risks of that procedure or treatment. And then, number three, you're actually going to have alternative treatments that you may use, okay? Now, you could get a verbal presentation where you're just kind of like, kind of like what I'm doing right now, right? You can have a discussion with the physician, which is actually the preferred method by the courts, because they want to see that physician engagement between the patient and that doctor. A written information that you could just give them, pamphlets, videos, internet videos, YouTube videos, right? That a lot of you guys are utilizing YouTube videos for procedures, right? Just to see how it does. But they actually have videos for patients as well that are loaded up on there. And then diagrams or charts trying to describe to them what the procedure is, risks of that procedure, and anything alternative. Okay, now, what do you disclose, right? When you're disclosing the risks, do you disclose, like I always analogize this to the pharmaceutical commercials. This may cause diarrhea, constipation, nausea, fever, whatever, you can't walk, or, they just name everything down the line, like rapid fire. You don't necessarily have to do that to gain proper informed consent. So what should you disclose? Things that are severe risk but low probability, okay? And we always say death, infection, right? Those are the two big ones. Less severe and higher incidence, or a risk specific to that procedure. Right? If you put a subclavian central line in, you may get a pneumothorax. Maybe, right? It's usually very specific to that procedure. Now, the rule of thumb, anything, death, serious injury, limb or organ damage, right? If you mention those things, for the most part, you're okay. Minor events that happen greater than 5% of the time is like a numerical answer for those mathematically inclined people, like Dino. I'm just pointing you out, Dino. General risk, infection, vascular neurological injury, or death. So, most people, I would say, would go more on the general risk side, and I'll tell you why. If you try to go more expansive and more more specific, then if you leave something out, you'll be looked at as, why'd you leave it out, right? But when you go with a more broader approach, a more general approach, which is what most institutions do, especially with their standardized sets for informed consent. If you just kind of broadly stroke these things, that protects you a little bit more. I don't know if I explained that correctly for you guys. Let's go to DNR real quick. Now, it's an order given by a physician to not attend a resuscitative protocol for someone in cardiopulmonary distress, right? It can only be written after a physician discusses it with the patient, or if they lack capacity, a patient surrogate. You guys see this all the time, right? Types of DNR, orders and code designations. DNR, do not resuscitate, obviously it means no ACLS protocol. DNI, which we kind of shy away from, right? Because why are we going to do one, not the other? It's no invasive airway establishment. A chemical code, which is basically your medications, epi, atropine, whatever the case may be, or a full code where you would utilize all supportive measures. Everyone always tells you this, right? DNR does not mean do not treat. But there have been numerous studies done that show that DNR patients get less aggressive care and treatment despite, there's a presidential directive actually to discourage this, believe it or not. What determines capacity? I told you as your physician, you have an unrestricted medical license, you can determine what, if a patient has capacity for something. So the ability to communicate a choice, understanding relevant information, appreciate the situation and the consequences, and the ability to reason about a treatment, okay? Now, if you can satisfy all those things and just specify, listen, do you really want a PEG tube? And if they can communicate that choice, understand, appreciate it, and reason about it, that's enough. That's enough, okay? They could not know what year it is, tomorrow, or think that today, that every day is Monday. But if they can really appreciate this, then they have capacity. Now, what happens when they don't have capacity, right? In 1990, Congress said about the Patient Self-Determination Act, and they attempted to improve end-of-life care with advanced directives, right? Part of this, I'll tell you, is for the greater good. The other part of it, I'll tell you, is probably financial, right? You have these people that are at the end of life. I mean, the vast majority of medical and healthcare dollars are probably spent there, vast majority. And this is actually an attempt by the government to try to stave that off. So in 2005, it was noted that only 29% of US adults had living wills. They actually wanted to increase that number. Now, these advanced directives as a whole, there's actually different types of them. Your living will and your durable power of attorney for health care, which is the next generation of it. But your living will was the initial advanced directive, and then it went over to this. I'll tell you right now, there's a caveat. If somebody tells you they have power of attorney, what does the garden variety power of attorney mean? Financial decision making. That's it. No healthcare decision making whatsoever. It has to actually specify medical proxy, healthcare power of attorney, medical power of attorney. Plain old durable power of attorney in legal speak is just financial decision making. Now, your living will takes effect when the patient lacks capacity, right? Outlines the type of care they would like, usually addresses cardiac resuscitation, ventilator treatment, artificial nutrition, blood products, invasive tests, dialysis, antibiotics, what have you, right? Now, from your experience, the living wills that you guys have seen, are they really that clear? Not clear at all. Not clear at all. And I give it because I think the new generation of elder law attorneys are actually really modifying these wills and making them relevant to the patient. So that has to be commended, because a lot of times they'll say, hey, they'll mention in there as a clause, if two physicians decide that the care is going to be futile, well, what's futile? Who decides that? Who defines that? When should you not, when should you pursue aggressive measures or not? And how do you know at that point in time when someone's in an acute situation whether or not they're going to be able to come back from it in that acute situation? It's very hard to make that judgment call in the heat of the moment. So, like I said before, it may not address the therapy. Language can be vague, like I previously stated. And it may not clearly indicate a code status. Like we talked about the whole DNI thing. A lot of these codes, when it comes to code status, because these are packaged individually now, you'll have, I just want a chemical code. You'll see that coming out right now. I don't want to be intubated, but you could do compressions till the cows come home. You know what I mean? These things are outlined nowadays. Terminal condition. This is always the kicker, right? Legal definition will result in death regardless of treatment. Regardless of treatment. And as you know, we can't predict the future, right? You never know when they're going to respond. Medical perspective, if not treated, can result in death. So you have a legal and a medical perspective to it. And then this is just a rule of thumb. A lot of states require two physicians to agree to something, to withdraw treatment, right? Most states. Some states allow the hospitals to develop their own protocol for this. So, and most of them follow this because you figure, hey, if you got two physicians on board, more than likely, it probably is a terminal condition, right? Durable power of attorney for healthcare provides for a surrogate to make active decisions. They can still outline what they prefer as far as treatment modalities. And like I said before, medical power of attorney, healthcare proxy, healthcare power of attorney. Regular one, only finances. Only finances. And you'll be amazed at how many times they'll be like, oh, I have power of attorney. But how many times do you guys really ask what kind of power of attorney? I bet you never. Am I right? So it's very important. Guardianship. Like I told you before, when you declare someone incompetent, you completely strip them of their rights. They can't own anything. They can't vote, right? All rights as a citizen are completely removed. So they become under guardianship. It could be guardianship under the court or by another individual. This is just a little thing that a little spectrum as far as the autonomy is concerned, right? You have complete autonomy on this end of the spectrum, and then as you lack capacity, the advanced directives kind of come into play, and then when you really are declared incompetent, you go under guardianship. Okay? A nursing home patient comes into the ER, he or she is in fluid sepsis, hypotensive and unconscious. No living will, advanced directive, or DNR order. No healthcare proxy or medical power of attorney. Can't reach the family, can't get consent. What do you do? All right, overwhelming, right? Good, the emergency exception. Of course, because it's presumed that the patient would want to live. If you have no other information, just go for it, right? One of my intensivists when I was in training would always say, intubate first, ask questions later. Right? Which I think probably applies to most of what you guys do. But you always presume that they would want to live, right? You want to preserve life as best, unless it's specified that you don't have to. All right. Same patient, intubated on the ventilator. Stable vital signs, has 2 peripheral lines for IV fluids and antibiotics. You want to put in a central line just in case pressors are going to be needed. Still can't reach his family. Do you place a central line? No. Not, right? The emergency exception only applies to the preservation of life, no more, no less. If they don't need pressors on board and you don't need to put a central line in, you don't need to put a central line in at that moment in time. Now, if it progresses to that point, then once again, the emergency exception comes into play for informed consent. All right. Surgeon's doing an appendectomy on a 76-year-old woman. Surgeon notes that the patient has an ovarian mass that should be taken out and biopsied. Patient is under anesthesia and no one is available to give consent. The surgeon believes that the mass should be excised. Can the surgeon perform the extra procedure? How many people say no? Show of hands. Oh, vast majority. Okay. Finally fooled you, right? This is analogous to a court case in North Carolina where the surgeon acted in the best interest of the patient because they had the duty to do what sound medicine dictated, right? Even though they did not obtain informed consent for the extra procedure, it was considered to be life-threatening at that point in time. And it wasn't a mass, it was actually a cyst, believe it or not. The mass was a hypothetical. But I could tell you that this case is precedent in North Carolina, but you could have almost a similar set of circumstances and it may not hold. This is what's tricky about the law. Every state has their own set of laws, right? Every state has its own set of precedent. So unless it's a federal case, because the federal law is the law of the land, you really can't determine how your state judicial system will react in certain situations. Now, the extension doctrine, as they call it, does not apply in elective cases, and then when extension should be anticipated, you still have to get informed consent for it. So if it was anticipated, hey, we may have to do this, as well as this, you have to get informed consent. This won't cover you. Okay. A neurosurgeon does not tell a patient that there is a risk of paralysis with a laminectomy. The surgeon believed that the patient really needed the surgery and did not want to scare the patient out of having the procedure. Can he or she do this? So you people are saying no, right? Say no, of course, right? Now, in the Canterbury case that I alluded to before, there is something in dictum, as they call it, where, largely dictum, right? Where they said that there's a therapeutic privilege, right? Where if you know that it's best for the patient to not disclose a certain amount of information, that you don't necessarily have to disclose it. But it by no means is law. And for the most part, most people would deem it as unethical, right? A physician starts to explain a procedure, the risks, consequences, etc. The patient states that he or she would rather not know anything about the treatment and trust that the doctor is making the right decision. Is the requirement of informed consent satisfied? Yes or no? Yes? How many people think yes? One person thinks yes. Two people think yes. Maybe. Okay, so right here, this is called the waiver of consent, right? Where the patient could be like, well, listen, you're the doctor, I don't want to know anything. But you should provide at least enough information that the general nature of the treatment is expressed, okay? In that way, the patient can understand what they are foregoing. So if you have to at least describe what the treatment is, how, at least go into it somewhat. And this is very vague. For example, there are risks inherent in the treatment if the patient chooses to not have more information than informed consent is satisfied. So if you at least say, hey, listen, there are risks with this, and they said, that's it, I don't want to know anything, you're actually okay. You're actually okay. So it's one of these things that are very on the fence, one of these topics. A 67-year-old female presented to her PCP with complaints of increased abdominal girth. She is very active and has a well-balanced diet. Nevertheless, her pants size has increased in the past year. The PCP offers a CT scan to further investigate. The patient refuses because she does not want to be exposed to radiation just because she has, quote unquote, gained a little weight. The PCP does not discuss the issue any further. 1 year later, the patient presents to the ED with intense abdominal pain / ascites. A CT reveals peritoneal carcinomatosis. Is the PCP liable for failure of informed consent? Yes or no? How many people think yes? All right. Overpower the no's. At least it looks that way, right? Absolutely. Absolutely. You got to tell them why you want to do it. You have to tell them, right? This is the Truman case, 1980. This is in California. Developed the principle of what's called informed refusal. So if you inform them what you are, what the test is or procedure is for, and they in turn still refuse it, then at least, you satisfy that requirement. Big example here, which happens constantly. Patient leaving against medical advice. You always say, hey, you can die, sign this paper, right? That's basically what, for the most part, that's how we deal with it. But technically, you should be elaborating a little more on what on what they are foregoing here. Listen, you have a pneumothorax. Listen, you have a bacteremia. You can die. You need IV antibiotics. We have to clear this infection. Are you willing to take that risk? And if they are, and they have capacity, you've satisfied it. Nursing home patient comes into the ER. Once again, right? He or she is in fluid sepsis, again, because it always happens. Hypotensive and unconscious. Still no living will, advance directive, or DNR order. No healthcare proxy or medical power of attorney. This time, a relative is in the ED. They do not want anything done. You are not sure if the rest of the family would agree to this. Do you accept their refusal of treatment? Do you continue with treatment? Excuse me? A relative. So you're saying it matters with relative, right? Whether it be the spouse, whether it be the children, whether it be a faraway cousin from Kentucky or what have you, right? Okay. But actually, you're a little stuck here. Say if it was a cousin, or say if it was, there's nothing else that you can go on. All you have is this individual in front of you. You don't have anybody else, right? You don't have no advance directive, nothing documented from previously. So now it's a judgment call. Now, you can treat as long as you express the urgency of the medical care to the relative, right? Now, if possible, get confirmation of this from another physician or ethics board. I can tell you practically, this never happens, right? And try to assemble the ethics board. That'll take you about 2 years. I'm just joking. At least a few days, right? A week, roughly? A few days at least. Okay, so if you decide to accept the refusal of treatment, be sure to document that the relative was informed of the risk and consequences. Okay? So once again, on the fence, but always document, and make sure you follow that doctrine of informed consent, right? Describe the procedure, risks associated with the procedure, alternative treatments. As long as you got that documented, you should be okay. 85-year-old male was brought into the ED for severe pain. He was diagnosed with multiple compression fractures. It was suspected that he might have advanced lung cancer. Patient suffered severe pain, 8 to 10 range. He was only given PO Vicodin PRN. He was not in RER. His pain meds were not changed for 5 days. Is the physician liable? Yes or no? Yes, okay? This is actually a court case, Bergman v. Chin, 1999. I believe it was in the state of New Jersey, too, where the court ruled that the physician's lack of action was egregious. Egregious because he did not treat pain, and he didn't respond promptly to it. The jury ruled that this was an example of elder abuse. Damages were $1.5 million. $1.5 million. Now I can understand why you guys get dilaudid down there, right? All right. An 80-year-old demented male presents to the ED with paramedics for respiratory distress. On exam, he appears quite disheveled. Once again, unshaven, malodorous, covered in feces. Despite this, there's no bodily injury that is apparent. Paramedics noted that the home is dirty with multiple pets, once again, urinating, defecating in the house. Patient apparently lives with 2 of his children. Should this be reported to Adult Protective Services? And you said yes, and definitely yes, okay? Now, as a side note here, I was looking up some of the literature when it comes to elder neglect and abuse. Adult Protective Services stated that about 30% of the reports were based on abuse, 70% on neglect. Neglect is obviously highly underreported. In New York, they had a study, and 1 in 23.5 abuse cases reported. Financial abuse was in 1 in 44. Well, 1 in 23.5 abuse cases were reported. And so out of the 23.5 possible abuse cases, only 1 of them were reported. Highly underreported, right? Out of those abuse cases, 1 in 44 were financial abuse, right? Collecting a check. How many times, right? And you hear stories all the time that the patient dies and they never report that. The body's like, there's a corpse rotting and they're collecting a check. And for neglect, 1 in 57. So obviously neglect, we talk about elder abuse, but elder neglect, once again, highly underreported, and we usually don't, mention it. If there's no bodily harm, you can easily say, you can easily kind of turn your head. But technically, you should be reporting this. And that's it. I got some resources from Advanced Directives for Healthcare in New Jersey, and here's a list of the multitude of references. Oops. Any questions? Oh, go ahead.
With the case with the surgery, I know that in your previous presentation you gave us a couple years ago that there was a case similar to that, and the physician should not have done the extra case, or it was like a board question of sorts. But was this like an exploratory lap where they were trying to find source and then they went ahead and removed the cyst or whatever tumor as well? Or because it doesn't seem like it was life-threatening.
At that point, it was not. If you're talking about that particular case, at that point, it was not life-threatening. They had informed consent for only one procedure. They noted that there was an ovarian cyst there, and they took it out regardless. Okay, it was not stated. It was not stated as being an exploratory laparotomy where they were just looking around to see if there's any issues or anything else going on. That at that point in time, and I'll tell you right, that North Carolina case is kind of in left field a little bit. Okay, the state of North Carolina allowed it to happen and said, hey, you know what? That's viable because the physician deemed that there was a life-threatening risk, but it's a very iffy case if that's what you're asking. And that's what makes it so tricky, because depending on what state you practice in, it'll tell you what exactly the amount of informed consent necessary to do something, right? So it's very tricky. That was an example, and I put that as an example of the extension doctrine, because you should at least know the exceptions to not obtaining informed consent for a procedure or treatment. And that's one of the exceptions, okay?
And with the Jehovah's Witness case, I agree with you about the first scenario where you wouldn't transfuse. In the second scenario, you would. Now, you were mentioning it doesn't matter if the patient has a card that's not dated and it's not witnessed, you would still go ahead?
I'm not saying it doesn't matter, but it at least calls into question whether or not they're truly a Jehovah's Witness, right? Could they have been a Jehovah's Witness yesterday and then, I don't know, we're going to change over to Catholicism? Who knows, right? So you don't know, and a lot of times when you have those variables in front of you, you question yourself at that moment in time, like, what should I do? Are they Jehovah's Witness or are they not Jehovah's Witness? So it's never clean, cut, and dry, especially in the heat of the moment. So what you do is you try to do the right thing, right? You transfuse to preserve life, and in this sense, you preserve life and you still got, you still got named and were held liable.
Did the card specifically say they didn't want blood products?
The card just mentioned that they were a Jehovah's Witness. It was like a membership almost card, what have you, in Canada. And I don't know. I didn't know it was a club, but it was kind of like a membership card. But it wasn't. There was no date placed on it, so they weren't sure if is this something that started recently? Is there something that this person was thinking about? And that's what came up in the actual court case if you read it.
Do you have a legal obligation to read through their wallet or purse looking for cards like this? Let's say if you just want to find their information to get the driver's license, and stop there. Or do you have an obligation when you searching through to stop and look for cards like this?
It depends on what you need that information for, right? If you're looking for identification, just identification, you find that license or what have you, you're done. Yeah, you could stop right there. I don't think you'll be, searching through like a Macy's charge card would really help you out, in the ER per se. This just happened to be, they were trying to gauge her identity. And at that time, this Jehovah's Witness card came, popped up, and they were like, whoa, look at this. And they weren't sure exactly what to make of it.
What would you do in that case?
What would I do? I probably would have done what that physician did. Because could you really, despite the fact that they went to court and they were charged with battery, you could probably live with yourself, right? Would you imagine, would you think that you had a chance to save somebody's life? You didn't. Granted, if they didn't want a blood transfusion, they didn't want a blood transfusion. If you were on the fence, where would you go? So I think I probably would have done the same thing. okay, the question was that there was a 19-year-old that needed a blood transfusion. The mother didn't want, the mother was Jehovah's Witness, didn't want a blood transfusion. Was the 19-year-old also Jehovah's Witness?
It's just the mother who is the mother who is not a minor.
Yeah. I mean, there's a lot of case law when it comes to minors, right? Minors, unless they have the mature minor doctrine, where if you prove that you sustain yourself, you could actually, give informed consent. Most minors cannot give informed consent, depending on what the procedure or treatment is. So, in that sense, if it was a minor and the parents were Jehovah's Witness and they needed a blood transfusion, the parents could say no, and that has to be followed. Now, in the case of a 19-year-old that at that point in time lacks capacity, you don't know whether they're Jehovah's Witness or not, and the mother or the parent, the mother's saying, oh, well, they shouldn't get transfused. Well, now it doesn't matter whether they're Jehovah's Witness or not. They lack capacity. That mother is the patient surrogate, right? So they're the ones that are making medical decisions for them.
So my question is, especially with that Jehovah's Witness case, a minor parent of Jehovah's Witness, don't give my kid blood. Or is it the case where you have a young kid or an infant, like I've had before, that comes into the ED with meningitis or symptoms of you want to do an LP, and they say no, I don't want you to do an LP on my kid, but they need it. So,
They have every right, Dino. Right. They have every right to. You have a right to refuse.
Don't you necessarily qualifitis or get the court involved?
Informed refusal. Informed refusal, right? That doctrine right there. You explain the procedure, the risks associated with it, why you need to do it, right? And as long as you explain alternative treatments, they could go with the alternative treatment.
What if there are no alternative treatments and the kid is bleeding to death in front of you? That's my question. And it's your treatment is going to provide life-saving treatment to that kid, and you have a parent that says that. Is there
Well, that's a sticky situation, right? Because now you got to think, what is this? Is this an abuse case, right? Or is it just informed consent, and they don't want to give you informed consent for whatever treatment that you're offering? That has to. I would tell you. I mean, that's a very complicated scenario. You would have to really determine whether or not there's any signs of abuse, especially physically. You guys hear about spiral fractures and bruises and what have you. I mean, if you see that there's clear signs of abuse previously, I would think you'd be justified in kind of almost trumping, what the parents say. But ordinarily, no. Ordinarily, not at all. Good.
So it's the abuse thing. In this area, who would we call?
In this area, they have New Jersey Adult Protective Services. It's a state agency. It's a child, DIFUS. Yeah.
See, I know that there have been cases before where you've had a young, 12 or 13-year-old kid that has a malignant tumor that can be treated using chemotherapy, but the family or the parents are Christian scientists and they don't want any kind of medical treatment. And I think the courts has ruled in favor. I remember hearing about this case where, the kid should have been treated, and they did give, custody to somebody to let the kid get treated.
Okay, I mean, I tell you right now, as a general rule, that usually doesn't fly. Because if it is a religious belief, they usually let it go, okay? As a general rule. I'm not saying there's not cases out there, especially state law cases, that's not the reasoning behind it. But yeah, But we're a very liberal state here in New Jersey, and I find that very hard to believe that would carry here in New Jersey. Yeah.
What about the situation where you have somebody where the patient clearly expresses to you, I don't want anything, and then they pass out the phone.
I would say document you had that conversation with them. It's already been, as long as you document, hey, this conversation when they had capacity at that point in time, they told me this. If that's documented, you should be fine. Good? Thank you very much, everyone.